Today I'll try to argue why it matters that we should be in charge of taking control of vascular access. And I'll be looking at the problem through AV fistula. The nephrologists, we who are supposed to be in charge of these patients, are often worried about fluid load, electrolytes, the cause of renal failure, and so on. And vascular surgeon or other surgeons whom we allow them to do the vascular access are often interested in very higher things in their specialty, like aneurysms and bigger things. So this poor AV fistula and other vascular accesses for hemodialysis patients are not really being looked in depth. So no doubt that, so we have a lot of lack of innovation in this vascular access over the years. So the optimal vascular access selection obviously is confounded by so many factors, and that is the reason why it differs from place to place. An important thing is the vascular access team and patient and provider logistics. And that is why it is very appropriate that we get into the leadership role and try to usurp the selection and doing these accesses and become the leader of vascular access to give the best to the patients and probably AV fistula in the present understanding. And we nephrologists, we better understand the complexity of dialysis process and the needs of our patients. And also, you should realize we understand or we appreciate the need for usable access with good flow. It has a lot of challenges, but it also opens a lot of new opportunities as far as the patient is concerned and for the nephrologist himself and for the betterment of the life of the patients. And results of nephrologists doing AV fistula has been coming from all over the world. There was a lot of reluctance from US, but the European centers were giving good, satisfactory results when compared to surgeons. So I put the caption as a necessity in Indian rural practice. And and the need was actually, it was out of necessity. And these are the results. And you see that the functioning AV fistula at the end of surgery or discharge was more or less equal, but the waiting period was much less for the nephrologist. On this foundation of continuity of patient care, from diagnosing renal disease and starting dialysis and doing vascular access by the nephrologist himself, it is a continuation of this care, and nephrologist is likely to continue to expand the roles in the future, from simple venous catheters to AV fistulas to interventions of accesses when they go wrong, and entry into cath lab and doing even renal artery interventions. We are slowly enlarging our role in interventional nephrology, and we should be taking control and lead from the front.
Thank you, Bala. And your point is very valid. It is not just the skill of doing surgery, it is also the passion.